Welcome. You are listening to IJD in Focus, the monthly podcast series of the International Journal of Dermatology, featuring the latest editor's highlights and a summary of our open access publications available to all.
Managing chronic inflammatory skin diseases such as hidradenitis, suppurativa, and psoriasis extends beyond clinical measures. In the March issue of the journal, we present why the management of these diseases should also consider patient-reported outcomes, treatment burden, and overall satisfaction. Successful therapy in both conditions is influenced by factors such as residual disease activity, the psychological profiles of patients, and the availability of new treatment options. The coexistence of psoriasis and atopic dermatitis can pose significant diagnostic and therapeutic challenges. In such rare cases, Janus kinase inhibitors may be considered a treatment option instead of biologics.
According to an original article by Hazelgruber et al., therapeutic burden has been identified as a potential predictor of response to biologic therapy in hidradenitis suppurativa. The authors analyzed the determinants of therapeutic burden in real-world clinical settings among HS patients to explain this concept and its utility as an additional tool for guiding therapeutic decision-making. In their cross-sectional study, including all consecutive HS patients attending a specialized HS clinic between 2017 and 2024, the primary variable was therapeutic burden, or TB. TB was defined as the cumulative sum of prior systemic treatment cycles and surgical interventions for HS. The authors also analyzed whether socio-demographic or clinical factors were associated with a higher TB. Of 557 HS patients, almost 51% were women, and the mean age was 41.87 years. Most patients were referred from general dermatology consultations. The mean disease duration was 17.52 years. Regarding disease severity, 46.5% presented with early stage 2, and about 42% had an IHS-4 score between 4 and 10. Before their baseline visit, 9.7% of patients had received biological therapy, mostly adalimumab, 88.89%. The mean TB was 2.42 systemic medical and/or surgical interventions, referral from general dermatology or other hospital departments, older age, longer disease duration, greater HS severity, presence of pilonidal sinus, and prior biological therapy were significantly associated with higher TB. These findings suggest that TB comprehensively captures HS severity and progression factors. This metric could prove valuable in aiding decision-making for HS patients by indicating when a change in therapy might be necessary.
Another study by Calderola et al. Found that, despite advancements in psoriasis treatment, a gap remains in aligning patient satisfaction with clinical outcomes. The article evaluates which clinical and psychological factors may impact treatment satisfaction in psoriatic patients undergoing long-term biological therapies. This observational, cross-sectional, single-center study involved adult patients with moderate to severe psoriasis, treated with biologics for at least 12 months. The authors collected socio-demographic characteristics and data on the course of the disease. They also assessed the absolute residual psoriasis area and severity index, the site of the residual disease, and the severity of pruritus through the visual analog scale. Satisfaction was evaluated using the Treatment Satisfaction Questionnaire for medication. The Type D personality scale assessed participants' psychological profile. Overall, 146 patients were included, and 82.1% were globally satisfied. Linear regression analysis showed a negative correlation between global satisfaction scoring and residual PASI. The multivariable analysis found a higher pruritus score and not reaching a residual PASI less than 2 as the strongest predictors of global unsatisfied patients. Other factors unrelated to residual disease, such as gender, class of biologic agent, and type D personality, have also been found to impact patient satisfaction. The study's findings underscore the complexity of patient satisfaction in psoriasis management and highlight the multifactorial nature of treatment success beyond traditional clinical measures.
In a letter to the editor included in this month's issue, Yatsuzuka et al. Reported on the first case of eczematised psoriasis successfully treated with upadacitinib. In recent years, treatments for psoriasis and atopic dermatitis have significantly advanced, with upadacitinib emerging as an innovative drug effective against both conditions. As mentioned in the article, Laufer et al. Proposed recognizing a subtype of psoriasis called eczematized psoriasis. Instead of the 17 dominant immune response activations seen in plaque psoriasis, they suggested that in eczematous psoriasis, additional pathways, such as enhanced itch perception via IL-17C and Th2 pathway activation by IL-17E, contribute to the distinct clinical presentation. Yasuzuka et al. Supported the proposal above, recommending therapies targeting both type 2 and 3 immune pathways, such as cyclosporin, methotrexate, apremilast, brodalumab, and JOAK inhibitors. Following upadacitinib therapy, their patient experienced immediate improvement in both the itching and skin lesions within 2 months.
This month's open access publications included a highly informative review on pediatric dermatophyte onychomycosis by Gupta and Taylor. The authors presented a summary of the epidemiological impact of the disease, as well as antifungal treatment options, special considerations for at-risk subpopulations, and methods to prevent infection and recurrence. According to the article, a systematic review of available epidemiological studies found the worldwide prevalence of culture-confirmed pediatric toenail onychomycosis to be 0.33%, with no significant increases in prevalence over time. Another systematic review of studies investigating the efficacy of various antifungals in treating pediatric onychomycosis found high cure rates and low frequency of adverse events with systemic itraconazole and terbinafine. However, the studies are few, dated, and lack impact because of small sample sizes. Comparatively, clinical trials implementing FDA-approved topical antifungal treatments report slightly reduced cure rates with larger sample sizes. Patients with immunity-altering conditions, such as Down syndrome, or those immunosuppressed because of chemotherapy or HIV, are at a greater risk of onychomycosis infection and require special consideration with treatment. Proper sanitization and hygiene practices are necessary to reduce the risk of acquiring infection. Early diagnosis and treatment of onychomycosis in children, as well as any affected close contacts, are crucial in reducing the impact of the disease.
Moving on to our last long format, open access contribution this month, a team of Latin American experts led by Ocampo Candiani published a consensus on the treatment of melasma. Melasma is a chronic relapsing hyperpigmentation disorder that primarily affects photoexposed areas, occurring most frequently in adult women with darker skin phototypes. The primary factors contributing to its development include sun exposure, sex hormones, for instance in relation to pregnancy, and genetic predisposition. Melasma is highly prevalent in Latin America, where many countries lie in intertropical zones and exhibit significant ethnic diversity because of centuries of intermixing among Native Americans, Europeans, and Sub-Saharan Africans. 9 Latin American experts formulated a Delphi-based consensus to develop a valuable approach for treating melasma in this diverse population. After establishing an accurate diagnosis, assessing the impact on quality of life, and determining disease severity, the consensus recommends mitigating known triggers and promoting rigorous photoprotection. Active therapy should be tailored based on individual characteristics, for example, pregnancy status, previous treatments, or skin sensitivity. Treatment options include topical depigmenting agents, systemic therapies, and procedural interventions, such as laser therapy, microneedling, and chemical peels. Periodic reassessment of the treatment is essential, with strategies adjusted if targeted outcomes are not achieved. Once clinical remission is attained, patients should continue using topical depigmenting agents and maintain strict photoprotection measures to prevent recurrence.
And this concludes the March episode of IJD in Focus. Thank you for listening. Until next time.